Welcome to my non-medical prescribing presentation. I will use the IPS prescribing competency framework throughout to discuss and appraise the following case study and prescribing decisions. Patient X is a 58-year-old Asian female and name has been anonymised to maintain patient confidentiality throughout this presentation as per the Nursing Code of Conduct 2018. Past medical history involved type 2 diabetes, LVSD, CKD2 and MI. Current medications are amipril, bisoprolol, atorvastatin, aspirin, metformin and linagliptin. Presented with symptoms of nocturia and dry mouth. She's no known drug allergies. Recent EGFR was 79, HbA1c of 64 and cholesterol of 3.2. Blood pressure was 126/70, heart rate was 72 irregular and a BMI was 34. Tiribayan 2020 summarises that a consultation is the meeting and communication between an individual and healthcare professional for knowledge and solution of a health issue. Using a consultation model which fully addresses the patient's agenda leads to the reported higher levels of patient satisfaction with the consultation. Carter and Berlin 2007. Throughout this consultation, I will use the Calgary-Cambridge 5-step consultation model. The Calgary-Cambridge guide is a practical model which provides the task complete but also considers physical, psychological and social aspects of the consultation. The diagnosis is uncontrolled diabetes. This has been diagnosed subjectively through HbA1c blood tests. HbA1c is a laboratory tested, reliable and valid measure of diabetes control recommended by WHO 2006 Diagnostic Criteria for Diabetes. Diabetes UK 2022 categorises hypoglycemic symptoms as above. As the patient presents symptomatic and there has been substantial rise in HbA1c, NICE 2022 recommend intensification of pharmacological treatment in addition to extensive diet and lifestyle measures. Medications were discussed with the patient to reach a shared decision as RPS framework following joint decision which is recognised as part of the Calgary-Cambridge consultation model step 4. Throughout the decision, benefits versus risks enabled the patient to make an informed joint decision about diabetes management. It was decided that empagliflozin would be the most appropriate method of treatment at this stage, following local and national guidelines. The decision included social and pharmacological factors and evaluating the likelihood of concordance, which can be illustrated in the table above. The EMPA-REG outcome trials was a randomised double-blind trial of 7,020 patients over 42 countries, randomly assigned empagliflozin 10 mg, 25 mg or a placebo, monitored over 3 years. The EMPA-REG outcome trial showed that empagliflozin is superior to placebo in improving glycemic control and reducing cardiovascular events, including mortality of patients with type 2 diabetes and established cardiovascular disease. Zimmerman et al. 2018 studied the 28.5% of the female participants in the EMPA-REG outcome trial and concluded this study summarised that the use of empagliflozin led to early beneficial effects on clinical, metabolic and heart failure outcomes in patients with type 2 diabetes with or without heart failure at baseline, which were already apparent within 12 weeks from initiation of the treatment. Although the female population seemed relatively small in comparison to the male population, based on this conclusion, it was enough evidence to help sway my prescribing decision. Warner et al. 2006 determined the long-term renal effects of empagliflozin secondary to the EMPA-REG outcome trial. They concluded that in the patients with type 2 diabetes and a high cardiovascular risk, empagliflozin was associated with slow progression of kidney disease and lower rates of clinically relevant renal events than the placebo when added to standard care. This helped me with my prescribing decision as the patient had CKD2. Kaku et al. 2007 investigated the effects on the Asian race of the EMPA-REG outcome trial. Out of the 7,020 patients, 21.6% were of Asian race. They found that EMPA was effective in 3-point major adverse cardiovascular reduction, which was consistent with the overall population. This was useful towards my prescribing decision as this was representative of an Asian population. However, further studies in empagliflozin in the Asian race may be useful. Furthermore, a double-blind EMPA-reduced study, Packer et al. 2020, was conducted with chronic heart failure to evaluate the efficacy and safety of empagliflozin 10 mg once daily as adjunct to standard of care heart failure therapy. A total of 3,730 patients were studied, 1,863 which had 10 mg of empagliflozin daily. 18% of this population were Asian. Empagliflozin showed superior in reducing the risk of the primary composite endpoint of the cardiovascular death or hospitalization for heart failure compared with the placebo. This helped my prescribing decision as the patient also has other comorbidities of heart failure, therefore would provide multiple benefits. The Asian type 2 diabetic population typically differs from type 2 diabetic populations in the rest of the world in terms of pathophysiology, lifestyle, example diet, and other disease-related factors, including genetic background and cardiovascular risk. Some of these are listed above. The UK Asian Diabetes Study, Bellary et al. 2008, identified many challenges in achieving more stringent targets in South Asian people. Although blood pressure and lipid targets were achievable, improvements in HbA1c and BMI were found to be more difficult to achieve in this study. Furthermore, a more recent study by Kalpana 2020 suggested there is need for exploring additional approaches to change motivation and behaviour through education. The research highlighted there can sometimes be barriers to diabetic care in Asian populations which may require an altered approach from that of a Caucasian patient's diabetes review. I will adopt this knowledge by incurring these influential factors and apply them to future consultations and when making prescribing decisions which will enhance my continual learning development. With considerations of the IPS framework, I arranged a follow-up in 4 weeks with the patient to ensure there were no ADRs. I ensured I provided patient information leaflets on empagliflozin, sick day rules, and access creditable online resources. A repeat blood test for HbA1c and UNEs is required in 3 months to obtain subjective measurement of the effectiveness of the new medication and safe prescribing. Pharmacodynamics. Empagliflozin is a reversible, highly potent and selective competitor inhibitor of the sodium glucose cotransporter. Approximately 90% of renal glucose reabsorption occurs in the first segments of the proximal tubule and is mediated by SGLT2, a low-affinity, high-capacity transporter. The remaining 10% is removed in the distal segment via SGLT1, a high-affinity, low-capacity transporter. Inhibition of SGLT2 decreases renal glucose absorption, promotes urinary glucose excretion, and reduces plasma glucose concentrations. As SGLT2 inhibition occurs through an insulin-dependent mechanism, the risk of hypoglycemia is low. Garni, 2011. Absorption. Empagliflozin is orally administered. It is rapidly absorbed with peak plasma concentrations occurring of 1.5 hours post-dose. Therefore, plasma concentrations declined in a biphasic manner with rapid distribution phase and a relatively slow terminal phase. The observed effect of food on empagliflozin pharmacokinetics was not considered clinically relevant, and empagliflozin may be administered with or without food. Distribution. The steady state of distribution is estimated to be 73.8 litres based on oral administration to healthy volunteers. Empagliflozin is 86.2% protein plasma binding, which is distributed into the tissues and fluid. Approximately 36.8% is proportioned into the red blood cells of healthy volunteers. Metabolism. Empagliflozin is primarily metabolized in the liver during phase 2 metabolism by glucuronidation. As it is a single mechanism, EMPA doesn't inhibit, induce, or inactivate the cytochrome P450 enzymes, and therefore doesn't react with any medications that pass through this process. Studies showed that there were no major metabolites of empagliflozin in the plasma, and each metabolite showed less than 10% of the drug in systemic circulation. Elimination. Through oral administration of empagliflozin, it exerts renal excretion. It was found that 54.4% was retrieved in the urine, which half of the drug was shown as unchanged, and 41.2% found in the feces, and most of the drug was shown as unchanged. Based on the population pharmacokinetic analysis, the elimination half-life of EMPA was estimated to be 12.4 hours. The steady-state plasma concentration of EMPA was reached by the 5th dose, which allows for once-daily administration, which should benefit to patient X because adherence is likely to be better. The BNF recognises that there are some interactions between current medications and empagliflozin. These included increased myalgia, increased risk of hypoglycemia, and/or hypotension. However, none were identified as significant, so as long as you were aware of risks, then it was a more benefit to have it than not have it. Empagliflozin is a prescription-only medication which is regulated by the Human Medicines Regulation 2012 legislation. This medicine has passed all the relevant testing to enable licensing and marketing authorization on the basis of safety, quality, and efficacy. This medication was prescribed in line with the Medicines Act 1968 through ensuring eligibility against the BNF and SPC. CQC 2012 acknowledged that the independent prescribers should work to the RPS competency framework and have responsibility to not prescribe out of their competency. This concords with the NMC Code of Conduct 2018, which identifies that you should recognise and work within your limits of competence as you are accountable for your actions. This level of competence within your field of work and medication use is often maintained through regular update courses. However, this has been limited during the COVID pandemic, as more courses have been via e-learning rather than face-to-face. Clinical staff should ensure they have sufficient indemnity insurance for their role prior to completing any medical intervention. The NMC states that having indemnity insurance is a mandatory requirement of the code. Failure to have this could result in removal of the register. The Mental Capacity Act 2005 is acknowledged above. NICE 2018 accepts that a patient can provide consent verbally or implied consent through actions, for example. However, they note if there's any apprehension about consent, capacity, etc., that we may need to consider written consent, or if someone lacks capacity to make their own decisions, best interests or power of attorney. During the consultation, patient X was involved in shared decision-making throughout the Calgary-Cambridge consultation model. This included discussing all pharmaceutical and non-pharmaceutical options, providing the education on the medication involving risk, benefits and interaction between other medications so she could make an informed decision of treatment. Follow-up was arranged in 4 weeks post-commencing the medication. Bloods will be monitored in 3 months to maintain safe prescribing as per the RPS framework. The RPS framework was also implemented for safe prescribing by giving her a follow-up appointment in 4 weeks, which gave a reasonable opportunity to discuss any queries with the clinician. SLIA 2022 acknowledges that the concept of shared decision-making can improve treatment of decisions and increase patient self-efficacy in carrying out the plan of care in the wider context of healthcare. This can be improve reduction of medication wastage and unnecessary cost implications for the NHS. In future consultations, it is imperative to incorporate the patient in decision-making when it comes to their care, as it's likely to improve their overall experience, concordance and adherence to treatment. I'll maintain this during my CPD. The RPS guidelines encompass prescribing professionally. This is maintained through adhering to the NMC Code of Conduct, ensuring you should only ever prescribe within your level of experience and competence. In accordance to Clause 6 of the Code, Professional Standards of Practice and Behaviour for Nurses and Midwives. Practice Standard 3.2 of Standards of Proficiency for Nurse and Midwife Prescribers 2019 states, you are accountable for your decisions to prescribe and must prescribe only where you have relevant knowledge of the patient/client's health and medical history. In regards to patient X, empagliflozin was discussed and chosen as the most appropriate option in relation to most recent guidance and knowledge. It was prescribed within limitations of recent training and knowledge of the clinician, the law, guidance, regulations and local policies for choice of SGLT2 inhibitor. There was sufficient information, past medical history and knowledge about the medical condition to justify that empagliflozin was the most appropriate drug of choice. Weech 2015 acknowledges that continuing CPD for non-medical prescribers is recognised as being pivotal in maintaining up-to-date knowledge and skills influencing prescribing competence. Some of the methods of CPD development are listed above. As part of my own CPD, I intend to maintain following the RPS guidance as a self-assessment tool to ensure I am providing safe, effective prescribing within my area of work. The NMC enhances the use of reflection and feedback from colleagues, which will enhance my prescribing experience as it will enable me to recognise what has worked well for me and my colleagues, learn from my mistakes and areas that I can improve in. Throughout transparency of any issues or hurdles which I face during prescribing, this may influence learning not only for myself but for others on where my own or other care within the practice can be improved and have a positive influence on future processes or policies. I plan to make a crib sheet about the Calgary-Cambridge consultation model with reference to the RPS framework. This will give me reminders and pointers of how to lead the consultation. I am going to maintain up-to-date prescribing knowledge by attending study days and completing e-learning modules around my areas of competence. Thank you for watching my presentation.